All right, so here, back on page 184, we said that the rough surface creates an increased probability of coronary thrombosis. Thrombosis or blood clot will result in myocardial infarction or an MI. In these pictures, they're trying to depict how a blockage, the formation of a blood clot, has resulted in the death of some area of the heart muscle. And again, depending upon how big of an area has died and the location of which area has died, that will determine whether you survived that heart attack or there was a fatal heart attack. On the next page, on 185, so we said that the MI, the myocardial infarction or heart attack, is caused by complete obstruction, blockage of blood flow. This results in changes in the electrocardiogram. These are depicted right here, and by next class meeting, we're going to understand how to read that. There's also leakage of myocardial enzymes into the bloodstream. Have we ever learned that when tissues are injured, the injured cells release enzymes into the bloodstream, raising the levels of certain enzymes in the blood? So that's exactly what happens here. There are three major enzymes they monitor that leak out of the heart muscle cells. Of the three, there's only one I want you to know because we've already learned it, and that's CPK, creatine phosphokinase. That is an enzyme found in all muscle cells, including heart muscle. Have we talked about that before? Remember the Lipitor exercise? If you've forgotten it, go back and review it. So here it shows a graph showing numbers of days after a heart attack, a myocardial infarction is the way we're going to call it, and can everybody see how the CPK level rose in the bloodstream? The higher the level, the higher the CPK level rises, the greater the degree of damage to the heart muscle. And the longer, the more days where it stays elevated, it means there's continuing to be more damage. So they monitor these cardiac enzyme levels. On the next page, on 186, what about the pain associated with a myocardial infarction or a heart attack? We had told you that if the heart muscle isn't getting enough oxygen, which is called myocardial ischemia, it creates a referred pain felt in the left side of the chest, left shoulder, radiating down the medial side of the left arm, known as angina pectoris. With a heart attack, this is a far more intense pain. The pain feels like it's originating right under the sternum, substernally, and then the pain spreads to both shoulders, not just to the left shoulder, but to both shoulders, and the pain then spreads up the neck into the face. So the person is feeling intense pain all around this area. People who have survived a heart attack have described the pain as if an elephant were standing on their chest. And I would think that an elephant standing on your chest would hurt a lot. So when somebody is having a heart attack, what do they give them for pain? Morphine. They put them on a morphine drip. They don't just give them a Tylenol and tell them to sleep well. They put them on a morphine drip. It's intense pain. Now, what do they do for somebody who's having this coronary thrombosis leading to myocardial infarction? They give them, typically somebody who's having a heart attack is placed on 7 drugs simultaneously, 7 drugs. I'm going to mention 3 of them. One of the drugs they put them on is an anticoagulant like heparin. Heparin is what's used in the hospital. It's commonly called a blood thinner. I don't really like that name because it doesn't thin your blood. It doesn't make it thinner. It prevents blood clots from forming. It's an anticoagulant. Now that only prevents any new clots from forming. It doesn't dissolve the existing clot that's creating the problem. The other thing they'll do is they'll give them TPA. TPA, we said, activates plasmin to dissolve that clot that's creating the problem. So again, does everybody understand the difference between what heparin does and what TPA does? Heparin prevents new clots from forming. TPA activates plasmin, causing fibrinolysis, which is the breaking apart of the fibrin clot that's creating the problems. That gets rid of the clot. Heparin doesn't get rid of a clot, it just prevents any more clots from forming. A third drug of the 7 they give, I will mention, they put them on a beta blocker. Why? Because beta blockers block adrenergic receptor sites, especially on the heart. Because if they're stressed, you think they're a little stressed if they're having a heart attack? So releasing adrenaline, being stressed, what's that going to do to their heart rate? It's going to speed it up. They don't want that. That'll put a greater burden on their heart. Their heart's already barely functioning. So they block the adrenergic receptor sites using beta blockers. Okay, so those are 3 of the 7 drugs that you typically put them on right away. All right, let's, we're going to come back to that picture that, on that page, but let's jump to 188. On 188, we're going to talk about the electrical activity of the heart. Now, all heart cells, on 188, incidentally, do you think any of this is in your book? Right, I know some of you are saying, what's a book? All right, it's all in your book. On 188, all cells in your heart can spontaneously generate action potentials. We had learned previously that the heart is referred to as being myogenic because it spontaneously is active. It does not require the nervous system to work. That's in contrast to skeletal muscle, which we call neurogenic. If you're wondering, when did we use those terms? Pages 101 and 102. Skeletal muscle was neurogenic, heart muscle was myogenic. Right? We need to know that for the last test. Now, having said that all heart cells can generate action potentials and contract on their own, not all heart cells generate action potentials at the same speed. Some generate the action potentials at a slower rate. Some generate them at a faster rate. The cells that have the fastest rate of intrinsic activity, or automaticity, are called the pacemaker cells of the heart. Now these heart cells, remember that all heart cells are electrically joined to one another. You learn this in anatomy. Because in anatomy, when you were learning about cardiac muscle, you learned that their cells are electrically joined together by what are called intercalated discs, or what in physiology we call gap junctions. So they're called intercalated discs or gap junctions. That means that once one heart muscle cell generates an action potential, it just spreads to the others. It spreads from one cell to the next because they're electrically joined together. So that's exactly what we wrote right here in letter C. Thus, action potentials generated by the pacemaker cells normally spread throughout the heart even before those other cells have a chance to generate their own action potential, so the heart functions as a single unit. Now, to help us understand how heart cells spontaneously generate an action potential, I wrote to see page 162. So let's return back to 162. This was back in the skeletal muscle physiology section that we skipped. So in the middle of page 162, so it says in the middle of 162, myogenic muscle tissues. And I hand wrote right above that neurogenic. Skeletal muscle cells are neurogenic. That means they depend upon the nerve supply. Heart muscle cells and visceral smooth muscle cells are myogenic. Myogenic. In fact, there are 3 terms that basically all mean the same thing. We originally wrote them all on page 102, myogenic, automaticity, or intrinsic activity. Now, we've got a graph here. So what this graph is showing is on the x-axis time going by, and on the y-axis the membrane potential. And if you might be thinking, yeah, what's that? Oh, we've only been talking about it for about the whole semester. The membrane potential is the electrical voltage in the cell. So how do we monitor the electrical voltage or membrane potential in a cell? Answer, by inserting a microelectrode into the cell. So here it shows a heart. I labeled it because just from the picture you wouldn't know what it is. And here's a heart cell. So we can monitor the voltage changes in this heart cell by inserting a microelectrode and monitoring the voltage. And this is just a graph showing voltage changes in this cell over time. So you'll notice that it shows that this heart cell starts out with a membrane potential or voltage of about minus 60 millivolts. Now cells vary in their membrane, resting cell membrane potential. We've learned that it could be minus 90, minus 80, minus 70, minus 60, it varies. So here it shows a heart muscle cell with a minus 60 resting membrane potential. And it shows that it spontaneously depolarizes. It spontaneously starts to depolarize, and when it depolarizes to the critical threshold level, there's no stopping it and it fires off an action potential. This is also known as a pacemaker potential, this spontaneous depolarization. Now, what's causing this spontaneous depolarization or pacemaker potential is because there are sodium ion channels in heart muscle cells that spontaneously, on their own, open up. Now, your textbook actually described 4 different types of ion channels. I had only taught you about 2 of the 4 types. We had learned about ligand-gated ion channels that are activated or opened up by the action of a neurotransmitter, a ligand. We had spoken of voltage-gated ion channels that open or close in response to a voltage change. But in fact, there are 2 other types that are mentioned in your book, including something called a leakage-gated ion channel, where the ion channel leaks and it just starts to open up on its own. All right, well, I'm not so much asking you to remember the term leakage-gated ion channels, although they are described in your book, but that's basically what's happening. There are sodium ion channels in heart muscle cells that just start to spontaneously open up. And that leads to an increased permeability to sodium ions. And as the sodium ions start to flow into the heart muscle cells, it starts to depolarize. So as these sodiums start to spontaneously flow in, as positive charged sodiums flow in, the inside of the cell becomes less and less negative. That's called depolarized. When it reaches the threshold level, about minus 50, minus 55 millivolts, there's no stopping it and fires off an action potential. And we know that an action potential is what causes a muscle to contract. All right, so that's how the heart muscle cells, as well as visceral smooth muscle cells, spontaneously work. So we had explained previously that they do exhibit automaticity. Now you know how that they're able to spontaneously fire off action potentials on their own. Now, because all heart muscle cells are electrically joined together, once one of them fires off an action potential, it just spreads to all the other cells, even before these slower ones have a chance to generate their own action potential. So that, again, raises the question then, what are the autonomic motor neurons for? If you don't need the autonomic motor neurons to make the heart work, then what was the purpose of them? To vary the rate of activity. We wrote that on the next page on 163. At the top of 163, we wrote their job is to modulate the rate of activity, to speed it up or slow it down. So if you don't have any autonomic motor neurons to the heart will still fire off action potentials and contract on its own. It's just that the nervous system loses its ability to speed it up when you run and slow it down when you go to sleep. So it can't modulate it, so it just stays at a constant rate all the time. Yep.
Problems with the electrical activity of the heart would have to do with the sodium channels, these like weak forms that are opening.
You can anytime you ask what could cause a problem, anything you can imagine. All right? Fortunately, most problems are rare, but almost anything you could imagine has gone wrong in somebody.
I think for the electrical.
Well, we're still talking about more electrical things. We're not done yet. So back on page 188. So on 188, we've talked about the initiation of an action potential in heart muscle cells. Okay. what I've listed next in the middle of the page is the electrical refractory period or recovery period. We ever learned about that before? Yeah. Originally page 46. So if you've forgotten what it is, I would refer you back to page 46. We learned that when an electrically excitable cell, a nerve cell or a muscle cell, fires off an action potential, it needs a certain amount of time to recover before it can fire off another action potential. That's called the recovery period or refractory period. Now in nerve cells, the recovery period is about 10 milliseconds. In heart muscle cells, it's 300 milliseconds. 3/10 of a second, which is 300 milliseconds. So it lasts a long, long time, at least in the non-pacemaker cells of the heart. It's shorter than 300 milliseconds in the pacemaker cells. Now, let's try to understand why. Why is the recovery time so long in the non-pacemaker heart muscle cells? We can understand this by looking at the graph on the lower left. So, what is it showing? It's showing time going by on the x-axis, and the units are milliseconds. It shows the membrane potential, the voltage inside the heart muscle cell in millivolts here. Now, this picture shows the action potential in a non-pacemaker heart muscle cell. I drew right next to it, right here, an action potential in a nerve cell. A typical action potential in a nerve cell, it depolarizes as sodiums go in, it repolarizes as potassiums go out, and the whole action potential lasts 1 millisecond, and then it needs about 10 milliseconds to recover, and it can fire off again. In a heart muscle cell, just like in a nerve cell, as the sodiums flow in, it depolarizes, and way over here, the way it repolarizes is as potassium ions flow out. So it depolarizes and repolarizes in a heart muscle cell just like it does in a nerve cell. But the question is, why does it stay depolarized for so long before it repolarizes? That period where it remains depolarized for an extended period of time is called the plateau phase. This is called the depolarizing phase, the plateau phase, and the repolarizing phase. Now, they gave it the word plateau because when you climb a mountain and you reach the top of the mountain and it's way up high on the mountain and it's flat, that's called a plateau. So since a high flat area is called a plateau, this is a high flat area, and they call it the plateau phase. So why it stays depolarized for this extended period of time, almost 300 milliseconds, is that's when positive charged calcium ions start flowing in. So in other words, first, sodium ion channels open, depolarizing it. Then calcium ion channels open, allowing extracellular calcium ions to flow in. These are voltage-gated calcium channels that open. And then finally, voltage-gated potassium ion channels open, and the potassium flows out down its concentration or electrical gradient, repolarizing. So we wrote here that as long as there's this increased permeability to calcium flowing in, that keeps the heart cells depolarized. Because clearly, if first positive charged sodiums flow in, and then followed by positive charged calciums flowing in, you can't return the inside of the cell back to being negative as long as positive charges are flowing into the cell. Finally, when the positive charged potassiums flow out, then you can repolarize it. All right, so now we understand why it takes 300 milliseconds to recover between one action potential and the next, because the damn action potential lasts almost 300 milliseconds. The heart cells cannot possibly fire off a second action potential until the first one is finished. So if the action potential lasts about 300 milliseconds, you can't possibly fire off a second action potential for about 300 milliseconds. This is why we learned at the bottom of the page we could calculate the theoretical maximal heart rate. Remember how we did this? Because we said, this is old stuff, that if these non-pacemaker heart cells can fire up 1 action potential per every 300 milliseconds, that's the same as 1 action potential per every 3/10 of a second. Since each action potential is going to cause the heart to beat once, because it just spreads to all the other heart cells, causing the entire heart to contract. So that's up to 1 beat per every 3/10 of a second. So how many beats would that be per minute? Well, there's 60 seconds in 1 minute. So the second units cancel out. 1 times 60 is 60. 3/10 times 1 is 3/10. 3/10 goes into 60, 200 beats per minute. So that's the theoretical maximal heart rate, because the heart cells, the non-pacemaker heart cells, need about 200 milliseconds between 1 action potential and the next. Now, before we go forward, there's still one more facet to this. So we had said that in heart muscle cells, after the sodiums flow in, depolarizing it, then positive charged calciums flow in. But why? Why are calcium ions flowing into a heart muscle cell? Now, the first response could be because God made it that way, but there's actually a reason. We in last class meeting, we had talked about, either last class meeting or the meeting before, we had talked about the importance of parathyroid hormone. Parathyroid hormone is the hormone that ensures sufficient levels of calcium ions in the bloodstream. And we reminded you why calcium in the bloodstream is so important. We said it's needed for blood clotting, and it's also needed for muscle contraction. Now, in the top of the page, I reminded you at the top of the page that you all learned in anatomy that in skeletal muscle cells, calcium ions are actually stored in these little sacs inside the skeletal muscle cell called lateral sacs or terminal cisterns. Anybody remember that? They are associated with the SR, the sarcoplasmic reticulum. And there were these little sacs that store calcium. Again, I know you all learned this in anatomy. You may not remember it, but you learned it.
The striations?
Those are not the striations. The striations are the pattern, the arrangement of the actin and myosin protein filaments. But we call the tubular network of tubules inside of a normal cell, ER, endoplasmic reticulum. In skeletal muscle cells, it's given a special name, sarcoplasmic reticulum, because there are these little sacs that are right next to the transverse tubules of the skeletal muscle cell called terminal cisterns or lateral sacs that store calcium ion. So the action potential actually triggers the release of calcium ions from those sacs, and that calcium causes the actin and myosin proteins to move, causing shortening, contraction of the muscle cell. Now, while there is calcium stored in heart muscle cells, there's not enough calcium stored in heart muscle cells to fully contract. So additional calcium ion has to flow into the heart muscle cell in order for heart muscle cells to contract. So the reason why calciums flow into the heart muscle cells to allow it to contract. Now, let me just pause for a moment by saying this. I recognize that as I'm talking about all this junk, a lot of us are sitting here listening to this going, my God, I've got to be a nurse. I'm going to be a dental hygienist. Do I really need to know about any of this stuff that he's talking about? And the answer is an emphatic absolutely. Let me tell you why. There's a very important class of drugs called calcium ion channel blockers. Are they important? Yeah, they're widely used. They're used to control angina pectoris. They're used to control high blood pressure. All of you will be learning about calcium ion channel blockers. All right? Just think of the name, calcium ion channel blockers. They reduce the influx of calcium ions into heart cells and also vascular smooth muscle cells, and the effect on the heart is to slow the heart rate down. Now, it's beyond the scope of this class for me to start explaining this class of medications called calcium ion channel blockers. But if you're interested in nursing, nurse practitioner, physician's assistant, trust me, you will not get through the board exam without knowing calcium channel blockers. But the future dental hygienists are thinking, but why do I need to know it? Fine, nurses need to learn it, but why would I need to? Because they always ask calcium channel blockers on the national board exam on the dental hygiene. Why? Because they have a strange side effect. They are one of only 2 classes of medications that cause enlargement of the gums called gingival hyperplasia. The other class of drugs that enlarge the gums abnormally is Dilantin, which is used to control epileptic seizures. They always ask about calcium ion channel blockers because they want you as a future dental hygienist to recognize when you see these abnormal gums, if the patient is on a calcium channel blocker, that's why they have those weird looking gums. Because you're supposed to be an expert in knowing about gums. And you're supposed to know what medications the patient is on. So you just never know exactly why these things are so important. So it's beyond, I can't get into all of the details. I teach this in pharmacology, but I mention it in physiology so that to give you a jump start in understanding this of what you'll be learning in pharmacology. But you will all learn about calcium ion channel blockers, all of you. And they will have usually questions on the board exams pertaining to it. Okay, now before I go any further with this, also I want to backtrack because there's one thing I wanted to mention back on page 186 and I forgot to. So let me just mention it right now. Back on page 186, on 186, I wrote these words, but I forgot to say anything about them. So let me do that now. We had talked about on 186 a coronary thrombosis, a blood clot forming in the coronary artery. A thrombosis is a blood clot that forms in a vessel. An embolism is a dislodged blood clot. It is a blood clot that forms in one vessel and then gets loose, and this fibrin clot, this spider web-like clot, starts to move through the vessels of the body, and it may end up obstructing the flow of blood downstream at some distance from where it formed. That's called an embolism. Now, to help you better understand what I just said, let me give you a scenario, a story. There is a condition called thrombophlebitis. It's not uncommon. Anybody know what phleb means? Phleb means vein. So when you go to the hospital, you will see these people who have little badges, registered phlebotomists. That means they are registered to draw blood from veins. And that's where they draw blood from almost every patient in the hospital every morning, so they can run blood tests. It takes an additional licensing to draw blood from an artery. All right, but that phleb means vein. Any part of your body can become inflamed. That's called itis. So phlebitis is an inflammation of the veins. Now, when veins are inflamed, blood clots may form in these inflamed veins. That would be called thrombophlebitis. Now, it's not good to have blood clots in your veins because it means that you're not getting normal circulation through your veins. And incidentally, a common place for thrombophlebitis is in the legs. It's a common place. Circulation problems cause inflammation and you get blood clots. But you don't die because you've got blood clots in the veins of your legs. But this condition worries doctors a lot because these blood clots that are in the veins of the legs may dislodge and start to move. Let me remind you of circulation that you learned about in anatomy. So blood that's in the veins, all the veins, systemic veins in our body, converge and form the vena cavae. So the blood comes through the vena cavae to the right atrium. It goes from the right atrium to the right ventricle, from the right ventricle up into the pulmonary artery, and then it's going to go into the pulmonary capillaries. So this blood clot that may have gotten loose from a vein in the legs goes through the vena cava, right atrium, right ventricle, pulmonary artery, and may end up blocking the flow of blood in the lungs. That would be called a pulmonary embolism. And so that's what worries them about a blood clot in the veins of the legs, is it may cause a fatal blockage of blood flow through the lungs or somewhere else. So you can get embolisms anywhere. You can have a cerebral embolism. So the distinction between the term thrombosis and embolism is whether it's a blood clot that formed in that vessel or whether it's a blood clot that may be blocking the flow of blood but actually originated or formed somewhere else distant from where it's lodged. So you should know that distinction between a thrombosis and embolism. Incidentally, in either case, they would give TPA to dissolve it, to dissolve the clot. All right, now, on page, I've talked about that. Let's look on page 189. On 189, so we had looked at this graph previously, and this graph is just reminding us that when you're in your 20s, the theoretical maximal heart rate is 200 beats a minute, just as we've calculated on the bottom of the previous page. And what we also notice is that as we grow older, what happens to our theoretical maximal heart rate? It goes down, it declines. Can't get it up like it used to. And that's because the heart cells need longer and longer to recover between one action potential and the next. We also talked about this target zone business, because what the target zone concept is we said that what will make your heart bigger and stronger and increase vascularization of your heart is making your heart rate speed up. So how fast do you have to make your heart rate speed up to make your heart become bigger and stronger? And the answer is approximately 80% of its theoretical maximum. You can see the target zone here is somewhere between 70 to 85%. All right? So it's somewhere between 70 to 85%. Some people, maybe 70% is fine. Others need 85%. But you got to get somewhere in that target zone. So just as an approximation, about 80%. So for people in their 20s who have a theoretical maximal heart rate of 200 beats a minute, 80% of 200 is 160 beats a minute. So that's why when you're doing your Zumba, or whatever you're doing for your aerobic dancing or your jogging or your treadmill, that's why they want your heart rate to get up to about 160 beats a minute and try to sustain that for 15 or 20 minutes or more. That's called a good cardio workout. And that will make your heart become bigger, stronger, more vascularized, and improve your endurance. So we've talked about all that before.